All right, let's take a look at ECG case number 12. Here's the original scenario. You respond to a nursing facility for a 93-year-old female. She's got severe dyspnea, and the patient's nurse knows nothing about her, of course, and she runs off as soon as you get there and tells you she's going to go get the paperwork. We all kind of know this scenario. Either they don't know the patient, it's the first time they've had him, or they just came in, they don't know how long the patient's been like this. But you have to, go with what you got. So you take some vitals and you get a blood pressure reading of 88 over 60, a heart rate of 48 beats per minute, a respiratory rate of 32 breaths per minute, and an O2 sat of 100%. I think this tells us a lot, but it leaves a lot of questions as well. The blood pressure of 88 over 60 doesn't mean anything to me without clinical findings on the patient. If the patient is pink, warm, and dry, and very lucid with a blood pressure of 88 over 60, I might not be that concerned. But if they're pale, cool, diaphoretic, and they maybe have some altered mental status, I might be more concerned about this blood pressure. The heart rate of 48 beats per minute could mean a few things. Now, if the blood pressure of 88 over 60 is hypotense for this patient, okay, if this 93-year-old female is generally hypertensive, and now she has a blood pressure of 88 over 60, that could be severe hypotension. So a heart rate of 48 beats per minute would be an ominous finding that, we're not having a compensatory tachycardia with that hypotension, which concerns me a little bit. Maybe she's on beta blockers. Maybe there's some sort of AV block, or maybe there's another reason that the patient has a symptomatic bradycardia causing the hypotension. So we're starting to get concerned with the numbers. A respiratory rate of 32 breaths per minute does go along with the patient having dyspnea, but an O2 sat of 100%. 100% O2 saturation tells you that this probably isn't a primary respiratory cause. Now, 93-year-old female, okay, 93-year-old female, you have to think of other causes of shortness of breath outside of the lungs, okay, outside of COPD or CHF, even though it's a cardiac disease, it does cause hypoxia. We got to think of things outside of that. And, with this condition, it could be a few things, but I like to think MI until proven otherwise. Shortness of breath can be an angina equivalent, especially in elderly females, very, very often. Okay, and diaphoresis. I know I don't say diaphoresis on this, but diaphoresis is also another reason to get a 12 lead and think maybe the patient's having some sort of cardiac event. And I should say unexplained diaphoresis. If you have, a trauma patient with a gunshot wound to the belly, you shouldn't be thinking MI, obviously. Okay, so here's the first 12 lead that I gave to go with this patient. And this 12 lead doesn't have, anything super acute, popping out at you. Let's just kind of take a look at it. We do see some P waves, okay? And I only see one P wave for every QRS, and the PR interval looks to be normal. And the P wave is upright in 1, 2, 3, AVL, AVF, and you can kind of tell it's negative in AVR. So that means it's probably a sinus P wave. A little bit prolonged PR interval. It's hard to tell with this, but it looks like it's probably a first degree AV block or close to it. Okay. Now I want to look at other things. So let's look at our QRS axis. Our QRS axis in the frontal plane appears to be normal. Lead 1 is up. AVF is up. That's a quick quadrant method way of doing it. If you don't remember, you can do the ECG axis tutorial. But really quickly, I'll do it on here. Lead 1 is over here. AVF is down here. And if you remember, if the negative side of lead 1 is over here, you would cross that out. And the negative side of AVF is up here. So you cross that out. And this is the normal quadrant. If you don't understand any of that, do the ECG axis tutorial. I highly recommend it. You can find that on my YouTube channel. So go ahead and subscribe to that really quickly and check that out. Okay, so let's look for other things. Now let's look at the precordial axis. The precordial axis looks normal. You have a mostly negative QRS complex in V1, mostly positive in V6, and the transition occurs between V2 and V4, and that is normal. So your precordial axis is normal. Now let's look for ST and T wave changes, okay? And I do see some. I think what stands out most to everybody is AVL. AVL's appearance with that inverted T wave, that down sloping. I've talked about this before. Okay, I've talked about this in a previous ECG case. If you don't remember me talking about it, I will post a link right now on the ECG to the ECG case. Excuse me. So go check out that one when you get a chance. And the other thing I see is these T waves that appear symmetrical and pretty tall in 2-3 and AVF. Symmetrical and pretty tall. So what I'm thinking right now is an early inferior wall myocardial infarction. An early inferior wall myocardial infarction. This doesn't have, STEMI criteria, so to speak. Maybe you have a little bit of elevation in lead 3 and maybe a little bit in AVF, but you certainly don't have 1 millimeter in 2 contiguous leads, which is kind of known to be the STEMI criteria. What I do see, though, these broad-based, these are symmetrical now. When you have a little bit of that ST elevation like you see in lead 3, you have to almost continue the T wave down. I'm not doing a good job of it on my drawing pad. Continue it down, and you see that it is a symmetrical T wave, which is never normal. It's always some sort of sign of pathology, one of those things being an early MI. And this finding in AVL, okay, that particular morphology, you almost only see with early inferior wall MIs or with inferior wall MIs altogether. It's often the first sign that you'll see, okay? So we have another update on this case. You also know that the patient is pale, cool, and clammy, so that tells us a lot. She's a little shocky looking with that blood pressure. She denies any chest pain and is pretty lucid despite the inability to provide much information due to her dyspnea. Here's the second set of vitals. You have a blood pressure of 90/60, okay? Heart rate's 48, so those two things are kind of maintaining. Respiratory rate 34, O2 sat of 100%, and the lungs are clear. All right, lungs are clear. That adds to us thinking this is a non-pulmonary cause of dyspnea. And yes, this could be considered symptomatic bradycardia, and there, you could go along those treatment lines of start with a fluid bolus. A lot of people forget that fluids will actually improve many bradycardias. All right, if you got to think about it, if the more fluid you put in the right atrium, okay, that's called preload. The more fluid that you put into the body, it goes into the right atrium, and then it goes into the right ventricle, and the right ventricle stretches, and it has this stretch receptor that says, we're getting more volume, we need to increase the rate to get this volume out. Okay, and that's called the Bainbridge reflex. And if you give fluids, you can actually trigger that reflex and hopefully get somebody's heart rate up a little bit. All right. This blood pressure isn't that low, but it might be low for this patient. If she normally walks around at 140/90, and now she has a blood pressure of 90/60, that would definitely stimulate an adrenergic response, causing her to sweat and be a little shocky. And the fact that she has a decreased heart rate with these shocky symptoms tells me either she's on beta blockers and she's not able to have that, adrenergic sympathomimetic response, or the bradycardia is causing the shockiness, okay? And I have a second 12 lead to show you. Okay, the rhythm's the same, but there are some changes, okay? If you remember the first 12 lead, it didn't look to be as deep in AVL. Okay, it looks like the T-wave inversion is almost more. Okay, it's deeper. And these T-waves may be taller and maybe a little bit broader. And in case you don't remember, I put both 12 leads right next to each other. So the first one is up top and the second one is on the bottom. Okay, this first 12 lead, I'm going to put a little 1, a little 2 here so you can remember. Now, the first 12 lead, looking at it, we see those T-waves in 2-3 and AVF. And even look at AVL with your reciprocal change. Now look at it over here. You definitely see some dynamic changes here. Not just that, but you're starting to see something happen in V2 and maybe a little bit in V1. This is ominous. This is a good finding to know what's going on with your patient. You got to pay attention to this stuff. So these broader based T waves lean me away from hyperkalemia. A lot of people may think hyperkalemia with this initial 12 lead number 1. Because of the symmetrical kind of peaked T waves. But remember, these have a blunt tip. Hyperkalemic T waves are very narrow and have a sharp tip. Almost if you touch the top, you would make your finger bleed from pricking it on that T wave. The second 12 lead tells us a lot more. It's got a broader base T wave, okay, maybe a little bit taller. It's obviously symmetrical. Sure, you don't have a whole lot of ST elevation here, but with those reciprocal changes in AVL, and this is a posterior wall reciprocal change over here in V2, you're starting to get posterior wall ischemia, or injury, in fact. If you were to flip that in your head, you'd start to see ST elevation. So we're seeing these things, and we got to think this is an MI. Maybe you don't call STEMI alert because you don't have STEMI criteria yet, or maybe your system doesn't allow you to call STEMI alert yet with a 12 lead like this. But go to a cardiac facility, and continue along the treatment lines of MI. Would I increase this patient's heart rate? Probably not. 48 beats per minute is not that bad. I'm going to give her fluids. I don't want to increase oxygen demand on somebody with an MI if I don't have to. This heart rate, it could be due to an RCA occlusion. The right side of the heart, we know, has a lot of our conduction system. In fact, the SA node starts in the right atrium. Okay, so when you have a right coronary artery occlusion, which most inferior wall MIs are due to a right coronary artery occlusion, you get arrhythmias very often, and one of those arrhythmias is a bradyarrhythmia like this. Now, if I were to go along lines of treatment besides fluids and oxygen, I might consider atropine. Okay, atropine would definitely be my first consideration because this is a sinus bradycardia. Granted, there might be a first degree AV block, and sinus bradycardias are almost always due to a hypervagal or exaggerated vagal response, which is perfect for atropine, or atropine is perfect for it. Now, I mentioned oxygen, and we don't want to be crazy with oxygen. The American Heart Association is now in line with treating oxygen like any other drug. Okay, it's only indicated in certain circumstances. If this patient's not hypoxic, having an MI, oxygen can actually make them worse. Okay, it causes oxidative stress. You don't want to give oxygen to somebody that's got 100% O2 sat, having an MI or having a stroke. We've known that with strokes for a long time, but it holds true for almost every other patient. Oxygen is a drug. Okay, now I wanted to show a hyperkalemic example because a lot of people thought hyperkalemia with that 12 lead. Hyperkalemia has narrow T waves. They're tall, they're peaked, and they're very sharp. Okay, and you can see here it doesn't generally localize like the 12 leads we had with inferior wall T waves, acute T waves. So these T waves here are more indicative of hyperkalemic T waves. And this 12 lead is from EMS12lead.com. Okay, and these again are hyperacute T waves. Here's another example. You can see them best in V2 and a little bit in V3. Okay, these hyperacute T waves, they're broad-based, they're symmetrical, and they're tall. I hope you can see the difference because it's very, very important. And you notice here that they localize. They can, the leads that you'll have ST elevation in generally had hyperacute T waves in those leads at some point. All right, it's a good thing because it's an early indication of an MI. It's like within the first 30 minutes generally you have hyperacute T waves. So you're early on. You can stop a lot of infarct from occurring by treating this patient appropriately, getting him to the hospital. Now don't think because the patient doesn't develop ST elevation that they're not having an MI. Think of what you're doing for treatment. If you have that original patient, okay, that I showed you here, and you give this patient nitrates, you may reperfuse that patient's myocardium on the way to the hospital, and they may never develop ST elevation as long as they're getting nitrates. You're causing collateral blood flow. You're hopefully improving their coronary circulation. So that's it for ECG case number 12. Here's the angio that goes along with the patient. This is the right coronary artery. Okay, it's coming off the base of the aorta, somewhere up there. Comes down across this coronary sulcus, and right there we have no blood flow. All right, and then over here you can see that it's completely reperfused after the cardiac catheterization, and they identified the critical lesion. All right, so that was your proof, and here's the ECG resource for this case. I want to give Dr. Smith's ECG blog a shout out. Dr. Stephen Smith is a great EP cardiologist, super smart. He has a lot of good rules to determine early repolarization versus anterior wall MI, Scarbosa's criteria. Really, really good stuff. If you don't know about any of that stuff, it's more advanced. He definitely speaks at a higher level, but his blog, if you go there and you start looking at the 12 leads and you read the stuff that he writes about, you're going to learn a lot. Okay, so I highly recommend going over there. If you have any questions at all, send me an email over to me. I'm Adam Thompson. My email is paramedicine101@gmail.com, and I will continue to post these cases. I hope you enjoyed this one. I will see you next time.